Welcome to the Learning Lab. My name is Roman Garcia. We're here again, and what I'm going to show you today is I'm going to show you a case where an individual or a patient came to us, and we utilized the formula, the program that we're advocating for corrections of bowing or knocking of the knee. Now, the reason I want to show you this case is because seeing is believing. And if you ask any orthopedic surgeon or most medical profession in the orthopedic domain, they will tell you that correction of bowing and knocking is an impossibility. The only way that you can do it is through a surgical procedure, basically what is called an osteotomy. Those surgeries are very complex, very intense, very invasive. I've seen post-osteotomies, and the picture or the result of such procedures after a few years after the surgery is aggressive degenerative changes in the joint. So that is the surgery is a way of correcting bowing or knocking over a short period, but over the long term the patient still develops degenerative changes in the knee. The surgery, like I said, is very intense. There's a lot of manipulation of tissue, and the consequence of the results is degenerative tissue. So in this case, I want to show you one particular case out of hundreds that we have documented to show you the proof that correction of bowing or knocking is possible if you follow our formula. Now, this is one particular case. Now, this patient, and Carlos, I want you to zoom in over here. This patient, I don't have the year here because the picture was, the year was cut off, but so you can see that I'm being legitimate with this picture. This patient came to us in February 27 of 2017. You don't see the 7 here, but that's when she came to us. This was her original x-rays. Now, as you can see, this is the right knee, this is the right, and then this is the left. Now, we're going to go over a lot of the things that we've gone over in the past. Now, we treated the right knee. As you can see, the right knee on an x-ray is much more involved than the left knee is. We treated the right knee. The left knee was not bothering her. Now, what you can see here, this is the right, this is the left. This is the inside part of the knee, this is the outside part of the knee. You can see that the inside part of the knee is very degenerative. The joint space width is, she has a little bit, but it's pretty much obliterated. The subchondral tissue, you can see an area right here where this subchondral tissue is very dry, very brittle. It's sclerotic basically, and it's collapsing on her. You can see some evidence of collapse right here. You see this concavity right over here. You compare with the uninvolved knee. You can see that it's not like that. You can still see the growth plate right over here. The growth plate on this right knee is pretty much obliterated too. You really cannot see a defining line as you can over here. Remember what we said before. This growth plate is a sign of degeneration being created inside the tissue. You can see that this is somewhat of an advanced case because this patient has lost the growth plate. She has it on her uninvolved knee. This was in February 27 of 2017. Then she came back to us because she experienced some swelling and she developed some suprapatellar congestion, basically a bursitis. That's basically what she developed. Now we did an x-ray as part of the clinical examination. I examined her. Clinically, the knee was about 50% better. And we took the x-ray, and now I'm going to show you the x-ray post 1 year after this picture was taken. Now, look at the difference. This is the fascinating thing. Remember what we saw initially. This is 1 year. This is 1 year ago. You can see here the joint space width is obliterated. The growth plate is obliterated. You cannot see it. This is what I mean about the growth plate. You can see this line right here. This translucent line right here. this opaque line right here. You see the right knee does not have it. Her growth plate, her subchondral bone is starting to collapse on her, it's becoming very brittle. Now this is 1 year after this picture. And here you can see, I'll show you, I'll show you the date. I'll show you the date on another poster. But this is 1 year after. Now look at the difference. The most impressive thing about this knee, this picture right here, is the growth plate. You see the growth plate right here. It reorganized itself. That means that the subchondral bone was healthier. Now the most obvious thing that stands out in this picture is you see the joint space width. You can see it. It's formed. You can see it. Just to refresh your memory. Joint space width, it's pretty much obliterated. Now you see it here. You see how it's formed right over here. You see the growth plate right over here. It reformed. The sclerotic area that she had on her original right over here, where this bone right over here was very dry and brittle, you can see it's no longer there. It reconstituted itself. The joint space width, it formed again. She has cartilage in this knee. And you can see here, this is the left, this is the right. You can see here how white this bone is over here, the left versus the right, the involved one. The reason is that even 1 year after, she's still using her left leg as her primary weight-bearing leg. So this knee is better on all facets of the examination, from the clinical examination, and especially the x-ray, but the knee is still not at 100%, but it's substantially better. And again, we see all the evidence of it right here. Right here, joint space width, growth plate, the subchondral bone, it's not sclerotic anymore, and obviously the most telling is this joint space width. Now, what I'm going to show you now is using the biometrics. So you can see how this knee went from bowing to less bowing, more of a neutral stance. Again, just by looking at it, looking at the x-rays without the biometric readings, it's impossible to tell whether the person is bowing or not. You got to get some objective biometrics in order to determine that. And we've been through this before. This is this is initially 1 year ago. And again, this was done 1 year ago, and you see again, we've gone through this before. These are the biometrics that we use in our clinic to determine whether the person is bowing or knocking. And then these are the magnitude loads that the inside or the outside of the knee are being exposed to. Now, you can see here, this is the uninvolved. You can see the triangles here, the magnitude triangles over here are quite symmetrical. She's bearing more weight on the outside than she is on the inside. Especially now on the involved one, you can see that this triangle relative to this triangle here is smaller. Now the reason it's smaller is because the knee is more of is in greater bowing than the left uninvolved one. So she's converging her whole body weight on a relatively small area of the joint on the inside part of the knee, and that is extremely painful. That's part of the reason why with arthritic situations or arthritic conditions of the knee hurts, is because you're converging your whole body weight over a smaller area of the knee versus a knee that's relatively healthier. She has, on the uninvolved knee, she has greater surface area supporting her body weight versus the knee that's more involved, where she has smaller surface area supporting the same weight. So again, this is the biometrics initially, 1 year post. Now after we acquired the corrections, this is what you see now. The triangle, this is the right again, this is the right, and this is the left. This is the involved, this is the uninvolved. Now, the interesting thing is that these biometrics concur with what the patient was experiencing, the results of the clinical examination, and then the general X-ray findings. the biometrics show that you can see it. This is the vectors right over here. You can see that this line is starting to cross. It's real close to the outside of the knee. Now look at the difference between one and the other. You see, this is 1 year after. This is initial. You can see the line here. The vector line is farther from the outside of the knee. Look how close it is at initial examination. Obviously, and what this tells us is that at initial examination, she was bowing more than she was 1 year after. And again, the magnitude loads concur with these vector lines. She has now greater weight-bearing surface area on the involved knee, which translates over into less pain because now her body weight is being supported by more of the surface area on the inside part of the knee because she's not in such substantial bowing. And again, the interesting thing is that these magnitude loads on the left uninvolved are still the same. They still have the same ratio. The outside is slightly larger than the inside. That didn't change. This knee was relatively normal. But the magnitude load changes as the bowing decreases. The same thing you will see with knock knee is the same thing. These magnitude triangles will start to create a more symmetrical appearance relative to the uninvolved knee. Now, you can come to me now. Now, how did we accomplish that? The way that we accomplished it is that this patient followed our instructions to the letter. And what we did is, and I think we went through this before, we broke it down into a formula. This patient did exactly as we recommended. She was very compliant. She basically followed the formula. She prepped the tissue. She manipulated the tissue. And then with time, the tissue adapts. And this is the adaptation. This is the adaptation of the result of following the formula. This is the adaptation right here. She went from extreme bowing to less bowing to greater surface area supporting the weight-bearing load, and all that translates into less pain. But basically what she did is she prepped the tissue, and I'm going to show you in a little while how she prepped it. She manipulated the tissue, and I'm going to show you how she manipulated. And then she allowed biological time for the formation, for the reconstitution of the joint. And what she ended up with was adaptation. Tissues adapt to their environment, but you have to change the environment, and you have to create an environment where these adaptations can occur, but they are time dependent. That's why the time is part of the formula. But the formula is very simple to follow. You prep it plus manipulation plus time equals adaptation. Now what I want to go through to show you first is the prep part of the formula, the variable. The prep variable of this formula. Now, how did she prep it? Now, what I tell our patients always is that the way that you prep it is you have to introduce energy into the tissue. Energy comes in many different forms that the patient can utilize, from as simple as a hot pack to as sophisticated as electromagnetic. Now, the way that this patient prepped her tissue was that she used the red light. She used a red light therapy in order to introduce energy into the tissue. In essence, what she was doing is that she was creating pliability in the tissue. And the way that she did it was using this device. You know, I'll bring it. So I'm going to use my assistant here, Anna, to illustrate how to use this red light therapy. This was her energy form that she used in order to create pliability in the tissue. Now, this red light she used as it was directed. Now, this is a very easy device to use, to learn how to use. It can be used continuously. Now, what I recommend to all our patients is that if they are knocking, they concentrate. Let's say that the patient is knocking. That means when they're knocking that they're going to be exposing this area right over here to where all the convergence of stress. So when patient is in a knocking state, what they do is that they introduce the red light into the lateral compartment. You got to prioritize a compartment depending on whether you're knocking or whether you're bowing. So in this patient's case, since she was bowing, she concentrated the red light over the inside part of the knee. If the individual is in a knock-knee state, in a knocking degenerative state, what they would do is that they concentrate the red light over the lateral compartment. It's as simple as that. And they use it over and over again. There are certain instructions that go with this red light that I'm not going to get into now, but in essence, that's how they prep the tissue, is through utilizing an energy, a form of energy from the environment and concentrating onto the tissue, of which red light is a very effective energy that the patient can use in order to accomplish the prepping component of the formula. Now, the manipulation component variable of the formula is done through what is called an unloader brace. We like the DonJoy. We like the DonJoy brace. This is our favorite brace because for many reasons, but one of the primary reasons is that it's the simplicity of usage. Donning and doffing is extremely simple for this system. Aside from the fact that it's able to manipulate either bowing or knocking of the knee. In this patient, we used it for bowing. But the DonJoy system is a very effective smart brace that the patient uses in order to manipulate the weight-bearing vectors as they are falling on the knee. Now, we've gone through this before on how to don and doff the DonJoy unloader brace, so I'm not going to go into it now because everybody who's seen our video, they're already used to this system already on how to put it on and put it off and take it off. But basically, the DonJoy is a very easy to use, user-friendly system that the patient utilizes in a specific way that we recommend in order to manipulate the weight-bearing loads as they fall on the knee. Now, this hinge, depending on whether the person is in knocking or bowing, this hinge will be placed appropriately on one side or the other. If the individual is in a bowing state, as this patient that you just saw, the hinge will be on the outside. If the individual or the patient is in a knocking state, the hinge would be on the inside. The best thing, as I said earlier, the best thing about this brace is its ability to discriminate between the inside or the outside of a patient that's either in a bowing or a knocking state, and how easy it is to put on this system correctly. I've seen many unloader brace, and most of them are extremely complicated and bulky. This system is not. It's very light, very easy to use, and the protocol that we recommend encourages the individual to use this brace consistently. Because remember, the last component of the formula is the time ratio. Depending on the individual, depending on how involved the case is, time is a relative variable of this formula. But the average time that it takes for an individual to show these kinds of changes that I just showed you in this case is anywhere between 8 months to 1 year. Sometimes less, but that's pretty much the average. So time is a very important component that the individual has to work with in order to achieve these results that you just saw a little while ago. Everybody that's suffering from bow leg or knocking, with the right instructions, the right equipment, they can achieve these types of successes. And again, in this formula, the only equipment that you really need is an energy delivery system. The red light does the job. A good unloader brace, of which the DonJoy reaction brace is the one that we prefer. There are others in the market that can be used, but this is the one that we prefer because of how easy it is to use. And then give enough time and do the right things over and over again, and you will be able to achieve these types of successes. Again, anybody who watches these videos, if you have any questions, I always have my phone number. The phone number is part of the video. There's a website or there's an email address that you can contact me if you have any questions about any of this equipment or the protocol. But just understand, if you're suffering from bow-legged, but if you're bowing or you're knocking, there is hope for you. You just have to find the right person with the right protocol to instruct you and follow you through what you have to go through in order to achieve these successes. Again, anybody who watches these videos, I want to thank you. Until next time.